So today I'll be talking about prenatal and pre-implantation genetic diagnosis. So after screening, we have come to diagnosis. Indications. So what are the indications of prenatal diagnosis? It can be done in any case where previous child is having some chromosomal abnormality or monogenic disorder. If ultrasound shows any major or minor malformation, when there is a positive screening test, or any of partner is a carrier of chromosomal rearrangement. If the partners are carrier for any monogenic condition, then also we can offer prenatal diagnosis. So what should be the pre-procedure counseling? We should first explain the nature and consequences of the disorder. And suppose if you are doing amniocentesis, then what are the risks and limitations for that procedure? What is the reporting time? What are the complications that may be associated? Sometimes we may not obtain sufficient sample, like in case of doing CVS, sometimes the sample may be insufficient and we have to repeat the procedure. So all these things should be explained. In some cases, the fetus will be affected. Then what should be the next options? That should also be explained before testing. So there are various techniques of doing invasive testing. It may be amniocentesis, where we take amniotic fluid. It can be CVS or placental biopsy to collect chorionic villi, and then fetal blood sampling to collect fetal blood. And also we can collect ascitic fluid or pleural fluid, urine in some cases. So to compare these two techniques, amniotic fluid can be done only 16 to 20 weeks, whereas CVS can be done at 11 to 14 weeks. The quality of the karyotyping is good in cases of amniocytes, whereas it is somewhat of lesser quality in case of CVS. The maternal contamination chances are high in case of CVS. It is around 1 to 2%, whereas in case of amniotic fluid, the chance of maternal cell contamination is very less. The chances of failure of growth are also there in both the sample procedures. If we are looking for fetal chromosomal abnormalities by karyotyping, then amniocentesis is a preferred method. But if we are going for microarray, it is a DNA-based test, then both CVS and amniocentesis can be done. So this is a picture showing amniocentesis. So here we take around 10 to 15 ml of amniotic fluid by inserting a 20 gauge spinal needle through the maternal abdomen and uterine wall into the fetal amniotic cavity. So the procedure is done under ultrasound guidance. So we can do karyotyping and other DNA-based tests on amniotic fluid. Early amniocentesis increases the incidence of telepathic coronavirus in the fetus, and the risk of miscarriage that is associated with amniocentesis ranges from 1 in 500 to 1 in 1000. Sometimes there can be leakage of amniotic fluid, but it resolves without any long-term sequelae. Rarely there can be needle-associated injury to the fetus. It is very rare. Sometimes maternal infection or intrauterine infection. So all these complications are rare in. Coming to CVS, so there are two approaches. It can be transabdominal and transcervical. So for transabdominal approach, 18 gauge needle is inserted in the placenta, and using a 20 ml syringe, by applying negative pressure, we collect the chorionic villus. So it is performed at 10 to 13 weeks of gestation. The primary advantage of CVS is that it is done early in gestation, and early results may permit early termination. The risk of abortion is higher in case of CVS. It is around 1 in 100 to 1 in 200. Now, in confined placental mosaicism, the possibility is there in case of chorionic villus sampling. So already we have studied yesterday. So in this case, the genetic status of the fetus and placenta can be different. So this discrepancy can be seen in 1 to 2% of cases, and it is common in trisomy 13 and 18 placenta. So in this case, a CVS result may be false positive or false negative. So this was a Cochrane review. So they have said that second trimester amniocentesis is safer than transcervical CVS and early amniocentesis. If earlier diagnosis is required, we can go for transabdominal chorionic villus sampling. Now coming to chordosynthesis. So chordosynthesis can be done for karyotyping, for hematological disorders, to look for fetal anemia, any hemolytic disease, to look for fetal RHD status in case of intrauterine infections, to look for coagulation disorders, and also to provide fetal therapy in form of drugs and intrauterine blood transfusion. So the site may be umbilical vein or it can be intrahepatic transfusion. So the fetal loss rate is around 1 to 2%. Then fetoscopy was earlier used to look for subtle structural anomalies and mainly to obtain a skin sample to look for inherited disorders of skin or some metabolic disorders to look for enzyme levels. But nowadays it is mainly used for fetal therapeutic procedures because other disorders can be diagnosed by using DNA-based test. So this is a picture of karyotype. Yes. So this is the GTG banding. So the disadvantage of karyotype is that the resolution is only 5 to 10 megabase. And on karyotyping, we cannot identify any complex rearrangement. We can identify marker chromosome, but the origin of that marker chromosome will not be identified. Sometimes there can be small subtelomeric rearrangements. So that can also be missed. Suppose there is exchange of material between 13 and 17 and the size of both the segments is around 10 MB. Then despite the size being more than the resolution limit, it can be missed. So the test that can be performed using either amniotic fluid or chorionic villus sampling include FISH. So FISH is done in interface nuclei. QFPCR, it is a DNA-based test to look for rapid aneuploidies, and MLP, it can also look for aneuploidy. It can also look for microdeletion and duplications. The reporting time for both these tests is around 2 to 3 days. Then next is microarray. So it has a very good resolution. And in microarray, we can look at all the chromosomes simultaneously. So the resolution of microarray is up to the tune of 200 for losses and up to 400 for gains. Then Sanger sequencing can be done to look for monogenic disorders, and fetal exome sequencing can be done in certain indications. Then coming to microarray. So in 2012, American College of Obstetrics and Gynecology, they have recommended that every woman who is undergoing invasive testing should be offered microarray, as around 1.7% of those females where ultrasound is normal, they are likely to have an abnormal microarray result. And if there is any structural malformation, then the risk increases to around 6 to 8%. So coming to tests which can be performed only on fetal blood. So they may be biochemical tests such as enzyme levels. They can also be done on the chorionic villus tissue. But nowadays with the DNA-based test, we prefer to do that the Sanger sequencing for these disorders. Sometimes we suspect intrauterine infection. So for that, we can do PCR, like PCR for toxoplasma, for rubella, like that, PCR for CMV, and we have to look for antibodies also. For hematological disorders, we can look for fetal anemia, and HPLC can also be done from the fetal blood. Now, the next part is the pre-implantation genetic testing. So this was introduced in around 1980s. So PGT is done when one or both genetic partners have a known genetic abnormality. And we are testing the embryo to determine whether the fetus is having any genetic abnormality. So the indications can be for monogenic disorders. So in that case, it is known as PGT-M. Suppose the partner is one of the partner is a carrier of translocation, balanced chromosomal translocation, then it will be called as PGT-SR, structural rearrangement. If the couple is otherwise normal and there is history of infertility for which we are offering IVF, then we can go for PGT-A, that is PGT for aneuploidy. So the indications for PGT aneuploidy include advanced maternal age. Sometimes in case of recurrent miscarriages also it can be offered, and if there is history of repeated implantation failure. So, but there is still a debate for the utility of PGT aneuploidy. So some groups are saying that PGT aneuploidy increases the rate of live birth after IVF, but other group is saying that it does not increase the incidence of live birth. So that is still a topic of debate, but in American Society of Reproductive Medicine, published in March 2018 that there is insufficient evidence to recommend the routine use of pre-implantation genetic testing aneuploidy in all infertile women. So that depends on the choice of the patient, the care provider, whether PGT-A is offered or not. So when we are when to do the pre-implantation genetic testing, so it can be done at the day 3 when the embryo is at blastomere stage. So at the blastomere stage, the number of cells are very less, so we have to remove only a single cell of embryo. When we are doing biopsy at day 5, 6, so the embryo is at a blastocyst stage. So there are around 100 to 150 cells, out of which 3 to 5 cells are removed. But in this case also, we are taking cells from the trophoectoderm layer, which give rise to placenta, whereas the fetus is formed from the inner cell mass. So if there is any case having placental mosaicism, so that can give rise to false positive or false negative results in the PGT also. The advantage of blastocyst biopsy is that the implantation potential is less affected compared to cleavage stage embryo. We can get more sample because more cells can be taken. But the disadvantage is that in this case, we have to do vitrification of embryos. So they have to be kept in the suspended animation. Then the next type is polar body biopsy. So in polar body biopsy can be done in cases where the mother is a carrier of balanced translocation. So in that case, we can analyze the polar bodies so that we can know whether the actual ovum is having the any abnormality or not. So this is the stepwise procedure for PGT. So the oocyte collection is done under ultrasound. Then fertilization is done using either ICSI or IVF. Then embryo culture is performed. So the biopsy can be done at day 3 or at the stage of blastocyst. So the abnormal embryos are discarded and the unaffected embryo is implanted back in the uterine cavity. So if you are taking this polar body, then sample is taken at the oocyte stage. So we will analyze the DNA which is obtained from the polar bodies. In the cleavage stage embryo, 1 to 2 blastomeres are taken. So the experience with this technology is the time of experience is more. So this is a well-experienced one. Now day 5 to 7 blastocysts, in this case 5 to 10 cells are taken. So there is a bigger amount of DNA. In this case, we can also detect mosaicism as more cells are available. So if any mosaic embryo is there, so that will also be detected. So the methods that can be used include PCR. So in case of monogenic conditions, we will do PCR. If we are doing for any chromosomal abnormality, then FISH or RSCGH will be done. And in case of monogenic disorders, NGS can also be done. But there are chances of misdiagnosis, so that can be a human error like transfer of a wrong embryo due to sample mislabeling. Sometimes a patient can naturally conceive during the IVF cycles, so that fetus can have disorder and we will think that the fetus we have implanted is normal. Sometimes all embryos may be affected, so that cycle will be lost. In case of mosaicism, there are 2 or more cell populations with different chromosomal complement. So the chances of mosaicism is around 20%. So if we are doing only PGT for monogenic disorders or structural rearrangement, then for aneuploidy, we have to do another test after the implantation is done. Sometimes there can be de novo variants. So there are certain disorders that are not present in the family, but they may arise in the fetus. So that are new disorders for the family. So that possibility will always remain. Some imprinting disorders can also occur after IVF. So it is said that the risk of imprinting disorders increases in IVF babies as compared to natural conception. And some cases can have uniparental disomy. There are some ethical aspects that are associated with PGT. So there was a concept of rescue babies. Suppose the elder sibling is having thalassemia. Now they want another sibling that is unaffected to transfer the bone marrow of the unaffected baby to the elder sibling. So that can have some ethical issues associated with that. And sometimes we can offer PGT for some adult onset conditions. So that is also an area for ethical concern. There are certain long-term effects of PGT, but they are not so well documented. So some studies have shown that the babies that are born out of ICSI, they have some social or cognitive issues, but that is not documented. There is no documented proof for that. For PGT aneuploidy, there is a requirement of further research to assess the clinical utility. So it is thought that some patients may benefit for screening for aneuploidy, whereas some patients do not benefit from PGT aneuploidy. So we have yet to identify the risk factors that have to be present in the patient to offer PGT for aneuploidy. Then the clinical significance of mosaicism is also not well understood. So earlier it has, suppose in one cycle, all embryos were mosaic. So they have implanted some embryos that were mosaic. So that has resulted in a live, healthy baby. So we don't know whether that mosaicism was present in placenta only or some type of rescue of trisomy has occurred. So this is also an area for further research. So coming to some case scenarios in which we offer routine prenatal diagnosis. So this is a family. So here you can see that two siblings are affected. This has married to a female and they are in consanguineous relationship. So now the lady is pregnant and they have come for counseling. So as you can see that this lady, this individual is having some autosomal recessive disorder, suspected of some autosomal recessive disorder, let's say thalassemia, and the wife is carrier for thalassemia. Okay. So the recessive allele is denoted by small letters. So we have denoted by DD and this carrier capital D and small d. So what is the risk of recurrence of this fetus being affected with thalassemia? 50%. Okay. So here comes the concept of pseudo-dominance. So in this case, 50% of the offsprings will be affected. So that is known as pseudo-dominance. So despite being a recessive disorder, the pedigree will manifest as a pseudo-dominant, as a dominant disorder. So coming to the next scenario. So now we don't know whether the wife is carrier for thalassemia or not. So how will we calculate the risk of recurrence in this case? Maybe thalassemia or some other disorder. So we don't know the carrier status of the wife, this female, we don't know. So then, yes. Yes. We will test for the wife, but if they want to know the empirical risk before testing, so that also can be provided. Suppose it's thalassemia, then we will directly go for carrier testing of this female. We will look whether she is a carrier for thalassemia. If she is a carrier, then the chances of baby being affected will be that with 50%. If she is not carrier, then the chances of affected will be 0. Chances of affect. Okay. So in that case, we can straight away do HPLC. But for some disorders where, like for autism or some other neurodevelopmental disorders, so where we don't know the exact, like sometimes we may get the diagnosis, sometimes we may not get. Okay, so these disorders are heterogeneous with multiple genetic etiologies. So in that case, we can offer empirical risk of recurrence. So this is the affected one, so DD, and this is the normal. So if the individual is normal, like for thalassemia, if we have tested and she is not a carrier for thalassemia, then the risk of occurrence of fetus being affected will be 0. And if she is a carrier, then it will be 50%. Okay. Suppose if if this disorder is having a carrier frequency of 1 in 90, suppose any disorder, then the chances of fetus being affected will be half into 190 into 100, that is 0.5%. Because the carrier frequency is 1 in 90, so the chances of this female being carrier is 1 in 90. Okay, and the chances of transmitting the defective allele to the fetus is half of 1 by 90. Okay. Suppose for some disorders, the carrier frequency is there in literature. So we can look like cystic fibrosis. So in our population, what is the carrier frequency? From that, we can calculate. So this will give the empirical risk. So the carrier risk of this female being carrier is 1 in 90 according to the carrier frequency that is available in the literature. So the risk of transmitting the defective allele will be half of that. And this male will always transmit the defective allele because he is affected. Understood? Father will always transmit the defective allele, and the chances of transmission of defective allele from the female will be half of the carrier frequency. Okay. So then we will multiply, and for percentage, we have multiplied by 100. Okay. So that was an example. Earlier, we used to provide empirical risk when DNA-based testing was not available for each and every disorder. So now, if we know the disorder, we can offer mutation testing or some other biochemical test like HPLC. So coming to next scenario. So this lady came to us with history of excessive bleeding during some surgeries. Appendectomy was done and ovarian cystectomy was done. And there was also bleeding disorder in brother. In sister also, there was a history of receiving factor VIII during childbirth and after tooth extraction. So they have come with the factor VIII levels. So the brother has a level of around 3.7%. And both the sisters have factor VIII levels of 8%. So that comes under mild hemophilia. So what are the possibilities in this case? Yes. Hemophilia is an X-linked disorder. So 3 siblings are affected. So we know that mother should be a carrier. So in this case, it can be a manifesting carrier for hemophilia. So brother is affected and these 2 females are carrier, but as some females can manifest, so this can be manifesting carrier. Or it can be von Willebrand disease, so which is an autosomal recessive disorder, so that can manifest in both males and females. And in von Willebrand also, factor VIII levels can be reduced. Yes, in some cases. So due to some reasons, in X-linked recessive disorders also, females can manifest the symptoms. So the main cause is skewed inactivation of the X chromosome. So the normal one is inactivated and only the abnormal one is expressed. And the second possibility is the autosomal recessive disorder, von Willebrand disease. So that may manifest as hemophilia. So now we did the molecular testing. So this brother was found to be carrier for a mutation in the factor VIII gene. So we know that the brother is having hemophilia. Then we did the molecular testing of this female who had come to us. So on testing, this female was found to have 2 mutations in the factor VIII gene. So this female was compound heterozygous. Means she was a carrier of mutation in both X chromosomes. Okay. So one she was inheriting from mother and one she was inheriting from father. Okay. So as these levels were in mild hemophilia category, so father might have mild hemophilia that was undetected. So in case of X-linked disease also, some families where both the mother and father are carrier of same disorder, they can manifest as an autosomal recessive disorder. Okay. So we have to do molecular testing to confirm what is the disorder. Suppose in this case, if we counsel that we think that the disorder is hemophilia. Then we say that 50% of males will be affected and all females will be unaffected. But now in this case, when this female is having defective allele on both the X chromosomes, then all males will be affected. Yes, he should be affected, but since we do not have any history of bleeding manifestations, so that's why I have kept as a carrier. So he should be affected. Okay, but for mild hemophilia, unless and until we test or if there is any surgery, like these two females also came to attention after surgical procedure. So that can be missed on clinical basis.
Even if
was done. And for the again,
in this case, we did the gene sequencing, factor VIII gene sequencing. Yes, by Sanger.
even if father is not symptomatic, it may be that his factor VIII level is, it's like
Yes,
it's not that low.
mild hemophilia, that is factor level more than 5%. So they may go undetected throughout their lifespan.
Then, ma'am, he will be a case only. He cannot be a carrier. Yes.
Pardon?
Anyway, he will be a case of hemophilia only.
It will be case of
He will not be a
hemophilia.
carrier. Although he is not bleeding, he's asymptomatic.
Not bleeding, but if he undergoes some surgical procedure, then he may have excessive bleeding and may require factor supplementation at that time.
We did not require
No, but we were expecting single gene disorder, so that's why for monogenic. Yes, hemophilia is an X-linked disorder. Skewed inactivation.
They are carriers only.
Yes, they are carriers, but when one normal X chromosome is inactivated, because out of two, only one X chromosome is active in females. So if the normal one is inactivated,
Okay.
then it is known as skewed inactivation. In this case, it was not due to skewed inactivation. In this case, it was because of defective allele on both the X chromosomes. So it was a homozygous state. These both X chromosomes have the defective allele. Yes, both X chromosomes. She is manifesting. She is a manifesting carrier, but not due to skewed inactivation, and she is not a carrier now. Because she is having a disorder due to compound heterozygous mutation.
Should this not be in the mother of the mother also?
Mother also had the mutation. She is not having disease because one X chromosome is normal. But these two females have defective allele on both the X chromosomes.
Because of skewed inactivation.
No, they have both two mutations. See, there are two mutations, exon 14 mutation and exon 22. So this exon 14 mutation, this male brother has inherited from mother. And these two females have also inherited the exon 14 mutation from mother. But this exon 22 mutation have come from father. Yes. So these are the different scenarios, but as hemophilia is a common disease, suppose there is a consanguineous family, both mother and father, they are related. So they both may be a carrier for hemophilia. In that case also, this was not a consanguineous family, but in consanguineous families, this chance is more likely to occur.
But the father should be affected. Why is the father not affected?
Like this, these two females, they did not have any bleeding manifestation as well. But when they underwent surgical procedure, there was excessive bleeding for which they were investigated. And then the factor VIII levels was found to be in the low range, but that is mild hemophilia. So now we know that both X chromosomes have a defective allele. So in this case, all males will be affected and all females will be carriers. So now what is there any use of prenatal diagnosis?
Father is bleeding, mother is.
So we can do prenatal diagnosis,
Normal.
but if they know that if whenever there is a male child, he will be affected. Whenever there is a female child, she will be a carrier. So in that case, if it's their wish, they want to have a normal child only, then they can go for prenatal diagnosis. Otherwise, for hemophilia, we have treatment also. So in this case, the counseling differs from a routine case of hemophilia, because in that case, 50% males will be affected and 50% females will be carrier.
The real case where female is transmitting.
Yes.
Otherwise, she-
Otherwise, she doesn't. No, females always transmit hemophilia.
Always
But in a
at
carrier
this stage.
state.
Yes.
And males, only 50% will be affected. Okay.
Female is with disease, है ना, ये करना है।
So any confusion? So coming to next case. So in this case, the previous child was the previous child was having features of spinal muscular atrophy. So this is also a routine case that we come across daily. So now, what is the next step? We will confirm the diagnosis by MLPA and we will say that the risk of recurrence is 25%. So here we have tested the baby. So this is homozygous deletion of exon 7 and 8 of SMN gene. So this is 0 whenever in MLPA, the final ratio for any probe is 0, then this is suggestive of deletion. So this case is confirmed to have SMA. Now we can say that risk of recurrence is 25% and we can offer prenatal diagnosis in the next pregnancy. Okay. So in the same family, if the baby has expired, then what we can do? So we will do the carrier testing of parents. Yes. So now in this case, we have done carrier testing and mother and father were found to be carriers. So earlier the ratio was 0 for an affected one, but for carrier, it will be around 0.5 because the number of copies has reduced to half. Okay.
Yeah.
In normal person, the ratio will be 1. So for those like who don't know the genetics for SMA, so there are 2 copies for SMN gene. Every gene has 2 copies. Likewise, SMN gene has 2 copies. If both copies are deleted, mainly exon 7 deletion, then the baby will have SMA. If 1 copy is deleted, then the individual is carrier for SMA. Yes. So in this case, both the parents were found to be carrier for spinal muscular atrophy. In this case also, we can offer prenatal diagnosis and the risk of recurrence will be 25%. Now the same family, another scenario we have tested, but only mother is found to be carrier. Father is not a carrier for SMA. Then what are the possibilities? The baby died due to SMA. The features were suggestive of SMA, but as we have not tested the baby, we are not sure whether the baby had SMA.
Father is normal and the mother is just a carrier.
Mother is a carrier, yes, but father is normal by MLPA testing. So there are multiple causes. Father can have a point mutation in SMN1 gene. So majority of cases will have deletion, but 2% cases can have point mutation also. So father can have point mutation in the same gene. So mother having deletion, father having point mutation, baby can inherit defective alleles from both the parents and can have SMA. So one
point mutation should be called the carrier.
They will be carrier, but they will not be detected by MLPA. So MLPA will show that this person is not the deletion carrier.
Then how do we check that?
By sequencing. Like in DMD, which is a more common disorder, if we are not finding deletion, then point mutation is there. Okay. So likewise in SMA also, majority of cases will have deletion, but some cases can have point mutation also. So we should not miss that. Okay. So if deletion is not there in one of the partner, then that partner can have point mutation, means change at a single nucleotide. Then next scenario can be since the carrier frequency of SMA is around 1 in 90, so the baby can have other disorder that has phenotype similar to SMA. Okay, so SMA can also be caused by multiple genes. So main is SMN1, but there are other genes like congenital myopathy can be due to multiple genes. So the baby can have congenital myopathy, but we are thinking that the baby had SMA. So there is another possibility that baby has some other disorder, not SMA. There can be cases of false paternity also. Some cases can have gonadal mosaicism. So the father is a carrier of deletion in the gonads, but when we are testing the peripheral blood, we are not getting the deletion. We cannot rule out mosaicism. And the next possibility is when father is a carrier of 2+0 genotype. So that is another rare scenario that is seen in cases of spinal muscular atrophy. So coming to 2+0. So this is a normal case. So we have two chromosomes. This is SMN gene. One copy is present on each chromosome. Okay. So when one is carrier, then one copy is deleted from one chromosome. And when we are testing, the copy number is half. So 2 has changed to 1. So that can be detected by MLPA. Okay. Now for 2+0 genotype, there is one extra copy on a single chromosome. So one chromosome has 2 copies and one chromosome has 0 copies. So in this case, when we are doing MLPA, so MLPA is detecting the total number of copies. So total number will remain 2, but 2 copies are on a single chromosome. The other one is having no SMN1 gene. So in that case, if the fetus inherits this chromosome, then the baby can have 0. So there are certain MLPA kits that can detect this type of genotype. Yes, this is the normal. No, this is showing gene, not deletion. This blue bar is showing the exon 7 of the SMN1 gene. So in this case, if the baby could be tested, then we could have a definitive diagnosis. So in some families, like previous baby, you could not test, but in this pregnancy, they had come and we have not tested because the mother is a carrier, father is not a carrier, or one of the partner is a carrier. And then they come with baby having features of hypotonia, and we suspect that this baby is having SMA. So one family has come to us that presented like that. So when we tested that baby, so we showed homozygous deletion. So that baby was actually having SMA, but the mother was carrier, father was not the carrier. So this was a real case scenario. 2+0 genotype. So although in less percentage, but this is a known phenomenon, and SMA is a very common disease. No, like the locus is same and same gene, but this is a maternal copy and this is the paternal one. That happens because some genes, they have tendency to duplicate. Yes. So they can be present in multiple copies. So understood? Any confusion? Ma'am, I cannot hear you. Last one. And actually the 2 copies are there on one gene. So this happens for some genes, they have a tendency to duplicate. So this is a phenomena that is occurring by itself. This is a spontaneous phenomena, but because the actual copy number is 2, we are not able to detect this condition by MLPA. So this 2+0 genotype, it is associated with some SNPs. So some polymorphisms are known to be associated with this genotype. So we can test for those polymorphisms. So if polymorphism is there, then we know that this case may have mainly with SMA. That is a known example. Otherwise, we can test the family members, like the parents of the individual and extended families, then also we can interpret. So I think this is a one more case. So to know that the father is a carrier of 2+0 genotype, to confirm. So we have an MLPA kit. So there is some polymorphisms that are associated with this genotype, 2+0 genotype. So by that kit, we can detect if this polymorphism is present, then we suspect that this individual is having this 2+0 genotype. For point mutation, we need to do gene sequencing. So as for genes that have multiple exons, we are doing NGS, but for SMA, we should not do NGS because this like SMN1 is there and SMN2 is there. So these two genes almost have a similar sequence. So the point mutation will not be covered in NGS. So better to do Sanger sequencing. So coming to next case. So this family was referred as both the partners were having sickle cell trait. So this husband and wife, they were having sickle cell trait. The husband and the brother, they were having occasional body ache and jaundice since birth. So this was not evaluated. The brother was not evaluated, but there was no history of blood transfusion. So they came to us for counseling during this pregnancy. So now we tested this husband and the wife. So husband was found to be compound heterozygous for 2 mutations. So this one is the sickle cell mutation. So C.20A2T. So for sickle cell disease, we have only 1 mutation. Okay. So this was for sickle cell disease, and another mutation was also there, that is 619 deletion. So this is for thalassemia. So this individual was having sickle beta thalassemia. And the wife was found to be a carrier for sickle cell disease. Okay. So now we draw a Punnett square to know the risk of occurrence of disease in the baby. So the husband is having sickle cell thalassemia. So we have drawn small s for sickle and small t for thalassemia. Now the wife is having only sickle cell trait, then capital T and small s. So the baby will have sickle cell disease, that is a small ss in 25% cases. The baby will be carrier for sickle cell disease, that is TS in 25% cases. The baby will be carrier for thalassemia in 25% cases. And the baby can have sickle beta thalassemia in 25%. Okay, understood? 25%. Everything is same. This TS, then SS, ST, and TT. So this ST risk of sickle cell disease is 25%, and sickle beta thalassemia is 25%. So sickle cell disease have different manifestations, and sickle beta thalassemia have different manifestations. Okay, and now we know that the father is also having sickle beta thalassemia with no symptoms. So we have to keep that in mind. Now the family wants to do prenatal diagnosis, but we don't know whether the father, why the father is not manifesting. So then we did MLPA for alpha thalassemia. So now this showed deletion in the alpha gene. Okay. So now we know why the father was not manifesting, because due to 619 deletion, the number of beta chains have reduced. So this created an imbalance between alpha and beta genes, giving rise to beta thalassemia. But this individual also has deletion of alpha chains due to alpha deletion. Understood? So now the number of chains, alpha and beta chains, are balanced. So that is why this individual did not have any symptom related to thalassemia. What I'm saying is that besides sickle cell, he was also having 1 mutation for thalassemia. So the number of beta chains is reduced. But he was not manifesting. Like thalassemia manifestations are due to imbalance between alpha and beta genes normally. So we want to know why this individual is not manifesting. So we did alpha thalassemia testing. So in this, you see that these are red dots, means there is a deletion. So deletion of alpha gene was also there, causing decrease in number of copies of alpha chain. So now they are again in balance. So if balance is maintained, then disease will not be there. Yes, that is why the hemoglobin becomes unstable. So primarily the family has come for sickle cell disease, but due to the features present in the husband and brother, and we examined, so there was also splenomegaly, so we decided to go for full testing, that is sequencing of the full HBB gene. So then we detected 2 mutations. So now we know that this individual should manifest as sickle beta thalassemia. There should be history of blood transfusions. So why this person is not manifesting? Then we tested for alpha chain. So deletion was there. So now this problem is solved. So that is why the individual is not manifesting. So for the fetus, so now we have tested the baby. So the baby was found to be carrier for only 619 deletion. Okay. So the baby is carrier for thalassemia. There is no sickle cell mutation, and there was no deletion of alpha gene. Understood? So in these simple cases, like SMA is a common disorder, thalassemia is also a common disorder. There also we can get a complicated scenario. So in that case, we first need to have a clinical diagnosis, and we use all the investigations to, like we have suspected a clinical diagnosis. So we should direct the investigations according to that.